Today, it is well understood that depression is prevalent in psoriasis and a well-established comorbidity of the condition. Multiple studies have shown that suicidality is also increased in patients with psoriasis. Despite its prevalence, dealing with depression may be unfamiliar territory for many practicing dermatologists. With that in mind, an expert panel of psoriasis and psychodermatology experts were brought together in July of 2019 to formulate a set of recommendations on how patients with psoriasis and depression may be better cared for in the dermatologic setting. After the panel convened, 3 of the physicians sat down to discuss the collective insights and recommendations of the panel.
Hi, my name is Dr. Koo. I'm professor of dermatology at University of California, San Francisco Medical Center. Thank you for joining me. We just convened an expert panel composing of both dermatologists, psychologists, and psychiatrists on how to best manage patients with psoriasis and depression. And what we're going to do now is to give you a capsule summary of what we have discussed. With me, Dr. Richard Fried, or Rick Fried, who is both a dermatologist and psychologist, clinical psychology PhD, and Dr. Mark Levo, who is chairman of dermatology at Mount Sinai, and one of the most prominent psoriasis experts in the USA. Now, the very reason that we convened this meeting is because, first, it has never been done before, to put psychologists, psychiatrists, and dermatologists together. And the concern that we all share is the fact that talking about depression is an unfamiliar territory for most practicing dermatologists.
For many patients, depression is, to a large extent, due to the disfiguration and reduction in quality of life caused by their psoriasis. In some cases, psoriasis may, in fact, be the entire underlying reason for their depression. The panel of psoriasis and psychodermatology experts collaborated on a consensus statement that addresses this issue and the role of the dermatologist.
Actually, I would like to start with consensus that we reached. And this is the whole, once again, group of dermatologists, psychologists, psychiatrists. First, depression is very prevalent in psoriasis. I think we all know that. And also, multiple studies have shown suicidality is increased in patients with psoriasis. Depression, suicidal ideation, suicides are also quite prevalent and increasing in our society as in general. Now, because of this, we all felt that it is important to evaluate the mental health of our psoriasis patients. But on the other hand, the other important consensus we reached is that when we talk about depression and suicidality, it's really the disease, not the drug. What I'd like to do is to first clarify, just as Dr. Fried mentioned, is the depression primary or secondary? Primary meaning that they had a tendency for depression anyway, maybe even predating psoriasis. Secondary is they're depressed because of psoriasis.
As Dr. Koo conveys, dermatologists are ideally situated to screen and properly refer for the formal management of psoriasis comorbidities such as arthritis. An identical strategy should be taken with depression. After screening, if the patient's depression is primary or a combination of primary and secondary, then a consultation with a mental health provider could be helpful. If depression is purely secondary to psoriasis, then a more aggressive psoriasis treatment may be warranted.
And it is our conclusion that treatment of psoriasis does not increase or cause depression, but the treatment instead can be important in improving depression. Now, the last statement that we all were able to come together on is that timely institution of highly and rapidly effective treatment may be critical in patients with significant negative psychological consequences of psoriasis.
One of the things that concerns me, and I think most clinicians, is are we getting there in time? Are we intervening in a timely enough fashion that there's not damage done that perhaps can't be reversed? And that's where embracing, number one, an agent that's rapid in onset, number two, that it's durable, and number three, gives tremendous clearing. And what we've all learned is that sometimes a PASI of 75 may look wonderful in clinical trials, but may not be enough to liberate the patient to go about their activities that they want for quantity and quality of life.
The consensus of the panel agrees that the more psychologically distressed the patient, the more essential it is that their psoriasis symptoms are resolved quickly. Among the anti-IL-17s, IL-17 receptor A blocker can be an excellent second-line choice due to its speed of onset and high rates of clearance, as long as the patient has previously failed another systemic agent for psoriasis.
We're talking about using drugs that are the most effective and drugs that are the most rapid acting. And as all of us know, one of the most, if not the most effective psoriasis treatments we have is brodalumab. And certainly I've published that it's the fastest medication we have for psoriasis. That's the one that has a REMS program for depression. And I will say, I think that REMS program is very easy. I think it takes me about 1 minute extra with the patient.
As Dr. Lebwohl mentioned, IL-17 receptor A blocker requires a risk evaluation and mitigation strategy, which may dissuade some practitioners from prescribing it to a potentially depressed patient. Effectively moving forward with IL-17 receptor A blocker for appropriate patients requires a few minutes of education and a patient-provider agreement.
Say to patients, this is a very effective drug. The data and the expert opinions do not support that it in any way increases likelihood of depression and suicide. And as stated, we believe, and the data shows, actually ameliorates depression. And say to them that yes, depression is common with psoriasis and in life, and we take that seriously, and we remain vigilant for impact of any medication and looking out for your welfare.
So I will say, there's a question that's, I think, on the mind of my patients, and I also say to them, this is one of the most effective, if not the most effective medication we have, and the fastest. And I preempt a question which I think they should be asking, which is then, why didn't you give it to me first? I say to them that in the package insert, it is required that you fail another treatment. It could be methotrexate or another biologic or cyclosporin. And the reason I didn't give it to you first is because it says that in the package insert. And they did that because there were 3 suicides among over 4,000 patients. And even though they said that no causal relationship was established, they put into effect this program where I have to actually mention it to you. You have to sign a little wallet card, which I give you. And all of that takes less than a minute. But now that I've explained it to you, that's what I would like to give you because it is so effective and so fast.
The consensus panel concludes, treatment of psoriasis plays an important role in ameliorating depression. The role of the dermatologist is not to officially diagnose or treat depression, but to properly screen and refer. Timely institution of highly and rapidly effective treatment are critical in patients with negative psychological consequences of psoriasis. Treatment should be tailored to include highly effective and rapidly acting. It is the combined hope of the panel that these recommendations provide a practical framework for managing patients with psoriatic disease and comorbid depression.